Good morning, one and all, to this live question and answer session as part of our webinar series, Equilogues 2017. Equilogues, as all of you know, is a series of webinars that we conduct as part of the Closing the Gap Health Equity Research Initiative in India, which is a project run by the Achutha Menon Centre for Health Science Studies, Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum. The project is supported by IDRC Canada. We're privileged to have with us today our speaker, Ms. Mita Deshpande, who is currently pursuing her PhD at Centre for Social Medicine and Community Health, JNU, New Delhi. She has completed her M.Phil from the same department, and today's discussion is largely based on that piece of research. The video presentation of her talk, titled Social Inequalities, Health and Wellbeing Among Dalit Women Agricultural Laborers, using the lens of dignity and embodiment, was uploaded on our YouTube channel, Health Equity India, and the link was shared with you a couple of days back. Today, Mita will elaborate further on this topic while clarifying our queries and doubts. She starts with a brief summary of her presentation. Over to you, Mita.
Hello, Malu, I'm going to begin.
Yes, sure, Mita.
Hello and welcome to all the participants of this live discussion session. Thank you for the introduction, Malu, and thank you to Professor Sundari Ravindran for giving me this opportunity. And a big thanks to Dr. Malu, Dr. Tanya, Mr. Bevin, Mr. Rajesh, and the entire Equilogues team. I'll begin with a summary of the presentation that has already been uploaded and sent to all the participants. Now, as you know, the theme that I've been looking at has been health and well-being of Dalit women agricultural laborers. During my M.Phil research, the question that I was looking at was the articulations of dignity, or what is the meaning of dignity in the lives of Dalit women? What is a life of dignity as articulated by them? And in the doctoral work that is ongoing, I'm trying to look at, take further the themes or the components or spheres of life identified by the Dalit women in the context of dignity, and probe those further, go deeper into those looking at health and well-being of embodiment. I should say that this study has been a small part of a much larger engagement with and relationship with the community and the women for about 15 plus years, of which about almost 5 years I was working with the Sanghatan as a full-time worker. So it's important for me to say that. The study takes a historical approach and a structural approach, which combines with interpretative methods by giving primacy to people's perceptions. Now, what is the meaning of health and well-being as they perceive it? What is the meaning of dignity in their life? The experience of discrimination or denial of resources, humiliation, how does that link with health and well-being or dignity? What has been given privacy. And as a public health student coming from this work experience, I found that within public health discourse, the space that is given to caste compared to class and gender was much lesser. And therefore, the motivation to do this kind of study, which looks at the experience of caste, of course, with its intersections with gender and class. The conviction is that histories of denial, histories of humiliation, histories of untouchability, chronic hunger, all this has to be made explicitly part of public health discourse. And understanding this will help us go to the why, or unpack the possible whys behind the health status variables and the health inequities, disparities that we see. The study took a Dalit feminist standpoint, which is one that sees caste hierarchies and patriarchy as intrinsically linked, And this is the feminist politics that puts right at the center the most marginalized. Now, to just briefly summarize some of the findings, dignity was seen as a component of health and well-being and an enabling force. So the women talked about, the idea of being a full and equal human. That was how they were expressing dignity, the meaning of dignity, and they brought together the economic and the social. So they were talking about resources, land deprivation, and talking about recognition, respect, non-discrimination. These two were brought together in the idea of dignity. They were talking about freedom, um, justice. So the concept of dignity that they brought together was equality. And they listed out spheres of life or areas where dignity was created or denied. So they had a whole list, for example, work, food, health, land, recognition. There's a whole list, but it's not just sufficient to have these for a life with dignity. They said, for example, it's not just that work should be there for a life with dignity. How is this work? What is the work? Is the work under caste-based labor relations, or does it give them a sense of freedom? So they had a very sharp understanding of each of these spheres. And for the doctoral work, I'm taking some of these selected spheres that they have identified for a life with dignity and looking at the idea of embodiment. Because each of these, like if you take work, there are layers and layers of meanings that come out within that. The context is very important when we're looking at perceptions, and here the context has been one of change. I mentioned in my presentation the coming of the Tungabhadra Dam and canal irrigation, which changed the agricultural ecology of the area. Rice came in, and suddenly you had this green revolution type agriculture along with dryland farming, both. But this led to a dent in the caste feudal labor relations. So here then I gave two examples in my presentation about two contradictions, which seem like contradictions, but when you look at the context of change and the lens of dignity, then it becomes clear. So health, they say, the women say, has gone down, but well-being has gone up. Now, how do you make sense of that? So health for them has gone down because of this change in food cultures with the they're eating this poison, the pesticides. A lot of the diets have changed, but well-being has gone up. There is a decline in overt forms of caste discrimination and untouchability. There is a change, and the region has witnessed a Dalit movement. So in that sense, they feel that well-being is better. Another contradiction that I talked about was when you look at different labor systems. So the women were actually preferring the contract group system or the Guttige system over the daily wage or Dinakuli system. Actually, this is a contradiction because the contract labor that is involved is much harder. It's more backbreaking. You're really pushing the body to the limit day and night. But this offers a certain freeing in the caste relations. Namma Swatantra, they talk about when they say once our group takes the contract, there's no constant presence of the landlord, or so the caste relations are, in some sense, broken. Then I also presented findings related to public health institutions and people's interactions with those, the differential treatment being marked out as poor, and how class operates, and also the whole idea of the dual health services that we have in India. They perceive that duality as as an indignity, where one system, the public, is for the poor, and the private is for the rich. So the commercialization and money being prime, this itself is seen as an indignity. So the lens of dignity allows us to look at public health interactions, public health programs, and look at responsiveness. So basically the study tried to look at caste, class, gender, inequalities and their reflection in the health of a marginalized community. I think I'll stop here with this summary and we can open it up for discussion. Malu?
Thank you, Mita. That is a very crisp summary. Now we shall start the discussion. We request our audience to kindly type in your questions and queries on the live chat in YouTube. Okay, without any delay, let's start off with the first question. Mita?
Yeah.
So in your presentation, you had mentioned that caste and gender
Hello?
work in... Hello, can you hear me, Mita?
Yeah.
So in your presentation, you had mentioned that caste and gender sort of works in interwoven ways and the interaction is not additive. So can you elaborate some more on this?
Thank you, Malu, for this question. I'll try to explain first a little bit about what I mean when I say that and give some illustrations from the field. So when we engage or learn from the life narratives of Dalit agricultural laborers, we see that there are multiple axes of oppression or structures of inequality operating together or intersecting. She belongs to the most marginalized caste. She is a landless agricultural laborer. So the context is of poverty and being of the lower income group, the class, and she is a woman. But these aspects cannot be neatly separated out and measured separately because that is not how they operate. They are intrinsically interlinked and they mutually constitute each other. For example, if we look at caste and class, here again in our conceptualization itself, we are understanding caste as both social and economic, having both social and economic aspects. So when you look at a denial of resources, land, differentiation in life chances, all this denial mirrored along the caste hierarchies, then we are looking at how caste and class are actually inseparable. So in my work, we look at Berriman, who writes that caste is institutionalized inequality, which guarantees differential access to the valued things in life. So it's important that we see both the dehumanizing social aspect and the material, so the ideological and the material together in caste. So similarly, when we talk about gender and caste, when we're taking the Dalit feminist standpoint that I mentioned, that standpoint is organically or fundamentally one that is talking about intersectionality. And it's we're looking at the position and the location of Dalit women, and their life experience is different because of this social location, and these differences have to be acknowledged. So that is what I'm trying to say when I'm saying that these multiple axes are actually interlinked and not additive. So, but through some examples, it'll maybe become clearer. One example that I give often from, which is from my research, is in one of the villages, there was a huge big struggle to find a place to defecate or a toilet. And this is a common experience in the lives of women and Dalit women, where there is no, sense of privacy and dignity to go and defecate. Now, in this village, the Dalit Keri was cramped and there was no space to build a toilet. These women were landless, and they used to go and go to the toilet behind the road. Now, as part of the panchayat road widening scheme, one fine day, all these bushes were removed, and suddenly the women had no place to go. Now, this came up in the Sangha meetings as an issue of dignity, as an issue of health, privacy. as what can be seen as a non-issue. But actually, the interwovenness of caste and class comes out here, because the women used to try, and they had no place to go, so they used to go to the fields of other agricultural fields. Often these fields were owned by the dominant castes, and these women used to be chased out with caste insults that get out of our fields. Then they took up this struggle. They went to government level, rung from the panchayat, taluk panchayat, zilla panchayat, MLA, you name it. And everybody had the same answer: show us the land, we'll sanction the scheme. And this was such a deep injustice and irony, where landless Dalit women were being asked to show us the land. But they didn't give up. They took up a contract with the panchayat for some work. They've decided to forego their wages and used that money to buy a plot of land, and then got the scheme sanctioned to build a toilet. So this struggle took about a year, and it brings out for me the interwovenness of how caste, gender, and class play in a person's life. Another example that I'll briefly give is about a labor process called Leki, which is basically a gendered labor, a caste labor. It's something performed only by Dalit women, and it involves sweeping the grain, the fallen grain. So after harvesting is done, after the crop has been taken away, there's still grain left on the earth. There's still hay and remaining uh, leftover plant crop, and in that the women search. They go with a broom and a winnow. They go in pairs and they search, and they shake the remains around, and the grain falls, and they sweep it off the earth and collect grain. Now this practice of Leki, now with agrarian systems being in such distress, we see other caste groups, other women also joining in. But this is predominantly something that only Dalit women do. Now, this is linked to their survival. They talk about how they have done Leki and managed to feed their families, because over a period of 10 to 15 days, they managed to collect a lot of grain. But it's such hard labor. You really, it's like a competition in a sense, because you're trying to collect whatever little is remaining. And so there are groups of pairs of women searching, walking from field to field, searching, sweeping it off the earth and collecting. So there's a sense of pride as well, that we were able to collect and grain and feed our families. But there is also a sense of feeling lesser, because this is looked down upon. There's a certain stigma attached to this practice. Oh, these Madiga women, they sweep and eat. So this practice of Leki also, for me, I think brings together the interwovenness of caste, labor, gender very well. These two examples bring out some of these issues. Thank you for the question, and back to you, Malu.
Thank you, Mita, for that excellent response. And now we
Hello?
Hello, Mita, can you hear me? Hello?
Yes.
Yes, you can hear me, right?
Yes, yes.
So I move on to another question. This is from Miss Rajalakshmi. She's from Chennai. So the question is,
Yeah.
what, according to you, are the commonalities and differences in the experiences of Dalit men and women with health systems in terms of dignity and well-being? Shall I repeat once more?
Yeah.
Shall I repeat?
Yeah.
What are the commonalities and differences in the experiences of Dalit men and women with the health systems?
Right.
In terms of dignity and well-being.
Commonalities and differences, there is a gap with reference to health services, interactions with health institutions.
Yes, what differences between men and women, commonalities and differences between men and women. Yes.
Okay. Thank you, Rajalakshmi, for this question. So my work has primarily been with the women, but since I have worked in the region with the community as a whole, I'll try to give some idea about this. I think the uh, very direct forms of discrimination in public health institutions, that is of, untouchability being practiced, those kind of collective memory of both men and women, they do talk about this. They talk about particular doctors who would practice this or those who wouldn't. And they But both of them now say that, men and women say that this has declined, and now the overwhelming feeling is more of being marked as poor. So the differential treatment that men and women feel as being from a poor community. Though they also say that caste is still operating, it's in the blood, and they can tell the language used is different. But the sense of money being prime and differential treatment because of that, men and women both talk about that. They both talk, the commonality again is in terms of the power equation involved, the lack of feeling heard, the lack of engagement with the doctor. They both talk about that. But I think for women, this is also they talk about it in the context of specific women's health issues, and in the context of childbirth and family planning programs, where um, they feel that the way that they are spoken to is very different from um, upper caste communities. The language that is used, the harsh um, awareness or convincing efforts that are taken up is very different across communities. Why have you given birth to so many children? You breed like pigs. These are kind of statements that women have recorded. Um, and also, the entire focus makes them feel that there is a sense of being treated as an aparadhi, that we have made some mistake. Tappu madavar, you have made a mistake by having children. So that element, that humiliation or that feeling of being lesser, the women talk about that in their interactions with public health systems. For men, the conflict is within the family, to get their pain recognized, to be able to say that our pains are not um, considered real. So the engagement with the health system, with the hope that there'll be a clear diagnosis, there'll be something, a label given, so that the family and the patriarchal setup there acknowledges that something is happening. So that struggle also is a difference between men and women. When does she access care? How does she manage to convince that she needs care? Um, yeah, so these are some of the thoughts that I can talk about in connection with interactions between men and women and the differences. Hopefully, that gives some idea. Thank you.
Thank you, Mita. So now I move on to the next question.
Yeah.
Okay, so Sunu, who is a PhD student at Achutha Menon Centre, asks, how have you conceptualized dignity in your study? So
Okay.
she asks you to elaborate on the conceptualization of dignity that you have used in the study.
Okay. Um, so I'll the idea was the study looked at an exploration of dignity in terms of the articulations of Dalit women themselves, looked at their perceptions and meanings of dignity. So that was given primacy. But in the initial conceptual framework, we decided to not look at how to explore this idea of dignity. And here, the relationship between dignity and public health, what brought these two ideas together was the you know interrelationships. So in public health, you're talking about interrelationships, you're talking about power and justice. Whereas even when you look at dignity, for me, the relationship part was important. Relationship to the self, to the society, community, collective. So dignity was seen as to look at self-worth, but how is that constituted in societal terms? So we looked at both. We looked at various literature, and literature on dignity is not so available, not so rich. So we had to look at different kinds of literature to arrive at meanings of dignity. So I looked at the works of Ambedkar, Phule, and I looked at a lot of writings on caste, the idea of institutionalized discrimination, the idea of graded inequality that Ambedkar gives. And these were all part of the conceptualization of dignity. And like I mentioned in the presentation earlier, the idea of being a full and equal person. This was something that was coming through in a lot of the literature, where um, the the sense of equality and being a complete person, as against being a lesser human or half a human or animal. This kind of grading of the human person, this was also used in the conceptualization of dignity, and this is actually something that really came alive in the field, because the women were giving instances when they felt like an animal, they were giving instances when they felt they've not been human. That's how they were, and they were graded in dignity. But for me, it was important to, in the conceptualization itself, to see that dignity is a part of health and well-being, and it's a component of it, and something that enables health and well-being both. So, and it brings together the economic and the social. We felt that it has that capacity. We felt that dignity talks about an imagining of change. It talks about resistance, and that conceptualization helped in the actual interviews and narratives, because we weren't only focusing on what the experience of discrimination has been. We were also looking at their struggles for equity, their struggles for justice, their struggles for dignity, as a collective, as part of a sanghatan, or as women. So these also get recorded in the conceptualization of dignity. Thank you.
Thank you, Mita. From your presentation, when you had mentioned that dignity has been like conceptualized both as an enabling force as well as a component of health and well-being. So,
Yeah.
Shri, who is a PhD student at our institution, she asks, so how should the system embody itself to ensure that dignity is actualized through
I
institutions?
can't hear you. There's a audio gap.
Okay, I'll just repeat the question, Mita.
Yeah.
Okay, Srijani, a PhD student from our institution asks, how should the
Yeah.
system be responsive
No, I
in
lost you.
ensure um, hello, can you hear me?
Yeah, yeah, yeah.
Yeah, so she asks, how should the system be responsive to ensure that dignity is actualized through institutions, health system?
Okay. Um, so when the women talk about we looked at how far state health institutions are embodying or actualizing dignity in terms of the legal framework. Untouchability is abolished. There is equality. There is citizenship in our constitution, in our legal framework. But it is the state institutions which have to actually grant this freedom. It's through these that the state and people are interacting. But because in our conceptualization, we see that state institutions are part of a larger social system. They mirror these inequalities. And the women talk about this. They talk about the loss of touch that they've experienced. They've taken up fights with the doctors that, and the doctors actually question them back that, do you think if I touch you, I'll get any other insight? And they say yes. They answer back and say, yes, you will get a different diagnosis. So all those experiences and experiences of being treated as poor, experiences of racism, corruption, all this they talk about in terms of how dignity is not being embodied. Now, how should the system respond to that? I think the women's sharp critique of the system the way it is points to the changes that need to be made. So when we look at health institutions with the lens of dignity, we are talking about responsiveness, we're talking about looking at the culture of the institution. How are you treating people who are coming there for care? So the intangible elements of responsiveness, that is the dialogue, the communication, the interaction, the dignity involved in that, as well as the tangible elements. The women were talking about the tangible elements that they wanted the doctor to give them time and attention and speak well. They also talked about the doctor not being there. They talked about medicines not being there, diagnostic facilities not being there. Those tangible elements were also seen as indignity because they felt all this is not there because we are poor. So the system has to address the tangible and intangible together to give a sense of, to embody dignity. It has to address not just the responsiveness in terms of embodying a sense of equality and care and in our speech, in the doctor and the system speech, but also in terms of the actual elements. They should be there. The infrastructure should be in place first. So, like I mentioned in an earlier question and answer as well, the dual system, the fact that there's one for the poor, one for the rich, that itself they talk about as an indignity. So the women are actually making a critique, asking for the system to move towards a universal system where this, um, you know, sense of dignity in the fact of the difference for the poor and the rich is coming out. Then also, um, yeah, I think I'll stop for now. I'm just looking at,
Okay, Mita.
yeah.
So the next question is by Dr. Srinithi. He's a PhD scholar at our institution. So he asks that, the presentation brings out the ubiquitous nature of helplessness in the lives of women. And so in this context, it looks like the concept of dignity in their lives is almost entirely limited and manipulated by the caste structure and maybe the class. So in this context, does dignity really act as an enabling force in any way
Okay,
in their life?
there's a lot of audio gap, but I'm just looking at the question that you have sent me.
Yes, can you just...
I think the point that I'm trying to make is that while there is a sense of helplessness that you point out in this context where caste and class and gender are together constructing the level of feeling of dignity or indignity. But when I talk about it, when the women talk about it as being an enabling force, they're talking about their sense of justice and their sense of equity that this concept of dignity embodies. So that this is what enables the struggles. There have been many struggles for better public health services. And it is this sense of realizing dignity that enables for this kind of work that the women do. Um, and without that dignity in public health institutions, without that dignity in other spheres of life, not just in public health institutions, they feel that well-being is not being met. So in that sense, I'm talking about the enabling force, that dignity, they don't, it's not some esoteric concept. They're talking about it in terms of actuals. So say having health enables work. Getting the capacity to work leads us to being able to feed our families, and therefore we have a sense of dignity. So ill health means something that happens, like when you're sick, you're not able to work, and therefore then there isn't a sense of dignity. So in that sense, the enabling force part, I don't know if I'm able to be clear.
Yes, yes, thank you, Mita, you were clear. So the next question is by Dr. Tanya. So she asks you to just share one way, maybe an illustration in which a public health center could ensure dignity of Dalit women approaching for maternal health care. Maybe an example.
Um, so from the field, if I try to give an example in the context of maternal health, I think one would be that there is a lot of weakness and anemia that Dalit women talk about, I mean, and has been documented. But the way that the system engages with this, the way that there is a sense of, oh, you people don't understand, you people don't, there is a blaming associated that is perceived as an indignity. Ideals of hygiene and good public health practice, nutrition, these ideals which may seem neutral actually are not so neutral in the way that they are projected onto Dalit women. So I think one way would be to actually engage with the reality of the life of the woman who is coming to you for maternal health care. And another thing that the women talk about, because a lot of the narratives, they talk about the process of childbirth, and they compare giving birth at home to giving birth in the PHC. And the scenario that they paint is completely different. At home, there is such a sense of support and care if they're delivering at home. There are people, other women who are around them, and there's never a shouting and a scolding. There is an encouraging. They talk about that. Whereas in the public and situations, they recount experiences of actually being, hit and pushed and talked to badly to at times of delivery. So these differences help us to see that actually a public health center has to invoke a sense of feeling secure, feeling safe for maternal health care. And in terms of the actual elements of maternal health care, also these should be provided. There should be proper checkups. For Dalit women, often all of these are overlooked, or access to care. There is a differential treatment there. So whether it's maternal health care or any other general health care which women are choosing to access, these elements have to be addressed. Yeah, Malu?
Yes, yes, thank you, Mita. So the next question is by Amitabh Sarkar from JNU.
Mm-hmm.
Yes, so he asks whether the social capital of women from the oppressed caste, whether that makes any significant impact in terms of upholding their community rights on a larger platform.
Yes, I think the role of social and cultural capital is very important when we look at caste, and when we look at caste and class and how it operates in different spheres. It's often said that, oh, this is only class. When you're talking about the upper castes, oh, it's not caste, it's class, and where people reach where they do. And when you look at the networks of social and cultural capital, then you see the underlying element of caste inequality or privilege. Similarly, in the lives of Dalit women as well, I think the social capital here is one of being part of a Sanghatan, is one of being part of a region which has seen a Dalit movement. And for every single community right or basic human right to be upheld, which the question talks about, there has been a struggle. Nothing that has been, at least, I mean, I'm talking about in my research context, every single basic right at the panchayat level or the health institution, everything has been as a result of a demand. And here, the social capital of being part of a collective, the women talk about it, the networks, or or being part of a larger movement. That is the only way that they've been able to access both individual and collective rights. So there is a sense of the state, indifference of the state, or the tyachara. So, for rights that are lawfully theirs, they've had to fight. And here, the network and social capital in terms of the collective and the Sanghatan has been prime in accessing these rights. So, um, yeah.
Yes, Mita, he goes on to ask another one. He says national programs like Manrega and other income generation schemes demands a kind of unconditional loyalty from its beneficiaries. So, do you think such programs, in a sense, ends up creating a parallel social exclusion in the lives of the oppressed? Have you noticed this in the context of your study?
Mm, well, I'm not sure if I can say that. I mean, I'll have to think about this, whether it's creating a parallel social exclusion. But I can say that in contexts of, chronic drought and hunger and food and hunger anxiety and lack of livelihoods in drought conditions, the Manrega scheme and other food security schemes have played a major role in the lives of women, in the lives of Dalit communities in my region of study. But again, these also mimic the same social realities in the way that they are implemented. So, here the question of understanding the culture of the program. So, even on Manrega scheme is not something that just gets implemented in a smooth way. Every time it's a struggle to get it implemented and to get the wages. It involves a lot of anguish and humiliation and struggle and social justice each time any work is taking place under the Manrega. So in that sense, yes, uh, these schemes are paralleling, just like the health institution is reflecting the social inequalities. These schemes also are being implemented in the same context. And each time for the women in my research study, it's been a big struggle to get them implemented, though they have had a significant impact in terms of addressing health, in terms of livelihood, in terms of the seasonal migration that would happen to and fro. In all of that, it does play a major role. I don't think it unconditional loyalty. I'll have to think about this a little bit further to see exactly what the question means. Thank
Thank you,
you.
Mita. Yes. So the next question is by Sabu Joseph, PhD student at AMC. So
Mm.
I think you've already answered his first question in a sense. He asks how do the women in the study define health and well-being. I think in your instances where you have given two quotes, I think you've almost explained that. But he goes on to ask whether you can think of any instance where improved well-being has affected the health of the women positively.
Hmm. Yeah, thank you. That's an interesting question. Yeah, I think we talk about how there has been a sense of improvement in because of a freeing of social relations, a decline in overt forms of untouchability. Um, and I think um, that does affect their health positively, because it also it it reflects in the kinds of labor relations and resources that women have access to. So when there is a freedom of labor relations, there is a decline in untouchability, you're able to access a lot of things which were earlier denied to you. So whether it's water sources or the PDS or you name it. Um, so that directly does affect health as well. So, and a decline in maybe a sense of dread and fear. So they talk about how the mind and the body is linked, and anxieties lead to illness and ill health. So, in a sense, a shift in well-being and reduction in anxiety about untouchability, they link it to also a better health. Though again, there is a shift that is being seen now because this research is over a long continuum. So there is a shift here again where well-being again, and there's a subtle change where they're again talking about different forms in which caste is continuing, and different ways in which untouchability is lurking. Um, yeah, but I won't elaborate on maybe specific instances, but definitely both are. There is a reciprocal relationship that the women talk about between well-being and health.
Okay.
Hello.
Yes, 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 we heard you. Mita, the next question would be from Bevin, who's a PhD scholar from our institution.
Hmm.
So he asks, from the way you've discussed the interactions of women with the health system, it looks like the discrimination that happens there is mostly class-based. So he asks if there is some way by which the women can be identified in, I mean, their caste identities are revealed through their clothes or language. So would you attribute it to caste and class equally, or is it mostly class-based? So that is what he's asking.
Um, I think it is definitely both, and women do speak about how, like I mentioned before, they say, "Rakta ಕೇಶಿಯಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತವೆ." It operates in the blood. Uh, ಇನ್ನೂ ಜೀವಂತವಾಗಿದೆ ಜಾತಿ. That is, it is still alive even in these institutions. At the surface, yes, they say that now it is more a sense of being marked as poor and class, and that is very, very important because they're critiquing the commercialization that is happening. But they also still have, in their perception, there is a sense of still um, this being there underneath. And they are, I mean, people know each other's caste backgrounds in a village setup. They know with the language, with uh, you know, women say that the way we look, the way we dress, they can tell. But still, the role of how class and caste is overlapping here, I think that is important, and the women talk about that more, the class aspect. But they use the word when they're talking about themselves, they're saying Madaru Badavar. So they're using the caste name and Badavar or the poor. Um, and the role of how public health institutions are treating Madaru Badavar. So even when they talk about it, they're seeing both these as operating together. Um, but yeah, there are markers, and there is a difference in language that they notice. Like when you're talking to, and when the doctors or any staff in the public health institution is talking to an upper caste person, they'll use the word re, the suffix re. The positions in which they are addressing the names, how you call out a name. Um, it's very different across castes. So these differences are still operating, but overall, the sense that they give is the sense of being poor and how that works against them in the health system. Malu?
Yeah, thank you, Mita. So we still have many questions which have been raised by our audience, but I think due to shortage of time, we will have to think about concluding it. So this will be your last question. This question is from Dr. Tanya Shishadri. So she asks whether having healthcare providers from Dalit communities in public health institutions address the issue of or the dignity concerns to a large extent. If not, what more would you suggest? Like, what would be the ways and means to address these dignity concerns in public health institutions?
Um, I think there is work being done on this aspect, that if the providers themselves are from Dalit communities, then what is the, how far is, what is the interaction like? And I think more work needs to be done on this. But, um, I'm not, in from my context, research context, um, yes, I think to an extent, yes, if the providers are from the Dalit community, there may be a greater chance. Like when you look at the social hierarchies within the public health institution, or the interactions between the doctors and the ANMs and the other staff, there as well, social hierarchies do operate. Um, so I think the overall interaction and how far the what is the culture of the institution can get affected if there are providers across caste and across, I mean, from Dalit communities as well. But this would need further research to actually look at how far this happens. I think, and just to take this forward, for one of the things that I think is very important is to have pedagogy and training within medical education, not just for doctors, but for ANMs, nurses, all other healthcare providers. How far in that pedagogy and training are we actually addressing? Where is the question of caste? I know that for gender, people are doing this work to look at curriculum and questions of gender, but I think similarly for issues of exclusion, dignity, caste, I think that has to be made part of the larger pedagogy to be able to address issues of the culture of institutions later on and responsiveness of the healthcare services. But I think it's a lot of the questions I feel have looked at dignity and public health interactions, and this is a major component of the research because access to care, access to health is something women identify as essential to feel completely human. But at the same time, I think the answers for a sense of dignity lie in the larger social system as well, not just in the public health interactions, because at a larger level, they're talking about food, hunger, livelihood, dignity in social interactions, so all these issues which are looking at structural inequalities and inequities are also linked to dignity and well-being. So I just want to, I know this is not part of the question, but I'm just adding this to just expand that the idea of dignity, I'm not only looking at interactions with public health institutions, the women are pointing to a much larger fabric for dignity, much larger canvas. Thank you. Malu?
Thank you, Mita. So with this, we have come to the end of this live Q&A session. So Mita, would you like to give any concluding remarks?
Um, yeah, I think I want to just again summarize by saying that what I just was saying, that yes, we're looking at responsiveness of health institutions, culture of the institutions, culture of programs, but we also need to look at the larger social system and how caste, what is changing and what is continuing. For further research, we need to look at continuities. Now, I had mentioned in my presentation, and I just want to quickly flag this. Women are talking about anxieties, deep sense of sadness, fear. So, how is that connecting to health and well being? Where is that coming from? And they're talking about their struggles for their child's education, that being, the prime sort of focus for all this labor and hunger is to imagine a different life for their children, and education being seen as a tool for change. But now caste is operating in different ways. There are roadblocks even after education in terms of opportunities and life chances, and that sense of dread and that aspiration, somewhere reaching a hurdle, that is giving them a great sense of anxiety. Um, yeah, I mean, for me, this is something I'm currently looking at. But I think it's important to look at how, the interconnections when you're looking at hunger anxiety, this other kind of anxiety, how the mind and the body are operating together, um, and how dignity is being created or not. And yeah, I'll just end with this. And thank you so much to everybody in the Equilogues team and for all the wonderful questions. It's given me a lot to further think about. I haven't really been able to address with specific examples for some of the questions, but I'll definitely maybe get back to you about this.
Thank you so much, Mita. So, on behalf of our entire project team, AIMCHS, we wholeheartedly thank you, Mita, first and foremost for that wonderful presentation, and also for your time, patience, and cooperation during this very engaging live question and answer session. We wish you all the best for your future work and other endeavors. I also would like to take this occasion to thank our audience for their patience and patient listening, and also for raising very pertinent questions. So thank you so much. We sign off now.
Hello.